Hello, this is Manny Ramos, your host of Rise Up, Real Issues and Stories of Every One of Us podcast. Joining us today on Rise Up are our two guests, Dr. Riza Muaricio and Dr. Kathleen Ferrer. But first, let me talk about who we are. I'm Manny Ramos, a board member of PNAA and a past president of the Philippine Nurses Association of Central Florida. I'm a professor of nursing at Valencia College in Orlando and an adjunct faculty at William Patterson University. With me today is my co-host, Mindy Ofiana. Mindy?
Hello, partner.
Hey!
Welcome, everyone. I am Mindy Ofiana, PNAA's Legislative Committee Chair, corresponding secretary of PNAA Foundation, and a past president of Philippine Nurses Association of Southern California. Before my recent retirement, I served as a dual role for the Chief Operating Officer and Chief Nursing Officer in one of the medical centers owned by KPC Group of Companies.
So, Mindy, how was your week?
It was a busy weekend.
Huh?
I was in Las Vegas because I attended our 25th annual convention and leadership summit of my alma mater, University of Santo Tomas.
Wow.
We also celebrated the 75th diamond anniversary of our College of Nursing. It was great to see my old classmates reminiscing our escapades as young nursing students. It was beautiful.
That must have been exciting. How was the crowd?
It was crazy. Everybody was just excited, very engaged. All the individuals were smiling.
Yeah.
But behind the scenes, the planning committee knew that there was something going on. But it was amazing that we are the only ones know that there was something going on and not the guests.
So that's a good thing.
That's good.
That's a good thing.
Yeah. This is learnings. There's a lot of learnings,
So,
despite the fact of all the plans.
Were you able to at least have some, leisure too? I know that was all business there, but you can't go to Vegas and not have some leisure.
No, I didn't play.
Oh.
No, because I don't play slots. I play cards.
Oh, okay.
And I play Paigao. And they were close to each other. And I'm just, because of the COVID, I was more careful.
Oh, okay.
And I just said to myself, no, I'm not going to play.
That's right.
Next time, maybe.
So did you fly? Did you fly into?
I did.
You
I
did?
flew.
Okay.
Yeah, from LAX to Las Vegas.
Yeah.
And people that were so we were all leaving on Sunday. And then there was apparently Southwest Airlines.
Yes, I heard.
Did you hear that news? That they canceled about 1,000 flights, and about 4 of our attendees got affected.
Yeah.
So, and she has an early flight at 6. By the time she went home, it was at 10:30.
Oh my! I feel sorry for them.
Others were, very creative in what they were doing. So they flew to LA. I mean, they drove to LAX, and from LAX they went and changed airlines as well. Was what happened to for the others. But
well, I'm glad. I'm glad you were able to have some time off. I know it's a reunion too. You must have been happy to see some old friends.
Oh yeah, yes. That's what I was saying a while ago. The escapades we had during very young nursing students, curious in many things, and so yes,
well,
it was
good,
wonderful.
Very good. Well, so. Now let's bring in our first guest for this second episode of Rise Up. This publication was made possible by Cooperative Agreement CDC RFA IP 21-2106 from the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of CDC HHS. With us today is our first guest for our second episode of Rise Up. Dr. Kathleen Ferrer is an attending faculty physician in the Division of Hospital Medicine, Division of Infectious Diseases, Special Immunology Section at Children's National Hospital. She's also an associate professor of pediatrics at the George Washington University School of Medicine and Health Sciences. Dr. Ferrer received her undergraduate degree in biomedical engineering from Brown University and earned her Doctor of Medicine degree from the Rutgers Robert Wood Johnson Medical School in New Jersey. She completed her residency in internal medicine and pediatrics at Baylor College of Medicine in Houston and eventually served as the medical director of the Baylor College of Medicine Bristol-Myers Squibb Children's Clinical Center of Excellence in Lesotho and assisted with a scale of pediatric HIV care, treatment, and prevention for the country. Currently, Dr. Ferrer serves as the education lead for the Children's National Global Health Initiative and is cultivating the next generation of global health leaders and educators by serving as a faculty mentor for Children's National Presidents and is co-director of the Pediatric Resident Global Child Health Pathway. As the lead physician for the occupational health COVID-19 response, she helped design and implement the organization's COVID-19 testing protocols, practice, and vaccination efforts for employees. Dr. Ferrer, good evening. How are you?
I am doing well.
Yeah, so you are based in Washington, D.C., a very exciting place to be.
Yes, it is. It's definitely, there's always something going on for sure.
So, why do you want to become a doctor?
Well, that's actually, so I think along with many of the nursing colleagues who are watching this podcast, I think it was a calling. Ever since I was a child, that's definitely something that I aspired to. I had very early exposure to the hospital environment. My mom is a nurse, and so she had trained in the Philippines and then came to the United States in the 1960s as an exchange nurse. She met my father and then decided to stay in New Jersey is where she had both me and my brother. And so I remember some of my earliest memories of being in the healthcare environment was my mom taking me to work, sitting at the nursing station, waiting for her to get done. And then I distinctly remember going to pick up her check. So, there was no such thing as direct deposit. But I remember walking over to the, payroll department, picking up her checks. The other distinct memory I have of my mom was, we would always get snowstorms. So not like Southern California and not I remember being just amazed that the hospital would send an SUV to come pick up my mom because she had to go to work.
Oh, wow.
My dad's an engineer. He never got an SUV sent for him. So, for my mom, it was definitely something that she was very passionate about, always, advocating for her patients. And I think that's something that she instilled in me. Yeah. So nursing was always very near and dear to my heart. And I didn't forget my father. I did do biomedical engineering as an undergrad, and then I decided to attend medical school.
I see.
So both of them are retired now, right?
Oh, yes. They're both retired. My mom was in nursing for over 40 years. She worked at the same exact hospital, Muhlenberg Hospital in Plainfield, New Jersey, for 30 plus years. She retired in her 60s, and now both of them are in their 80s living in Delaware.
How are they doing?
They're doing quite well. They are ready for this pandemic to be over so they can start socializing again. Our entire Filipino community that was in Piscataway, New Jersey, moved to Dover, Delaware, and so I think they have a more active social life than I do.
So you say you don't have social life, but what do you do on your off days, or when you're not working? You must have something like a hobby.
Yeah, the last 2 years have been just crazy, where it pretty much has been nonstop work because essentially, with COVID being novel, it was a matter of creating new processes, new algorithms, new systems, and trying to really figure out what this virus could do and how we could stop it. So I really haven't had time over the last now, what are we, 19, 20 months into this?
Yes.
But when I do have time, I do golf. And that I did pick up from my parents. So both my parents, they still golf. 81 and 82. And they still shame us because I will only golf 9 holes, and they'll be like, you have to do all 18. What do you mean you're not going to golf 9 holes?
How are the golf courses out there in Washington? I know in New Jersey they have a lot of beautiful golf courses. How is it in Washington, D.C.?
They're okay, but I will say that my favorite place to golf is the Philippines. My parents do. They created a retirement home for themselves in Tagaytay. So we tend to go there. They go there every year. And so they're there for the winter months, of course, to escape the snow and cold. So they're there from January to March or so. And then I typically go every other year to go visit them. And the golfing there is just phenomenal. Nice. So DC just doesn't compare.
That's true. So when was the last time you went home to the Philippines?
It was right before the pandemic, was January 2020. So we were in Manila and in Siargao. And I think my nephew got COVID, actually. But
how is he?
He did fine. He had a fever on the airplane on the way home. But everybody, I'm glad my nephews got to go to the Philippines before this all hit.
All right. Dr. Ferrer, you now work at the Children's National Hospital. How different is that from where you were at Baylor College of Medicine?
So, I did my residency in both internal medicine and pediatrics at Baylor in Houston, Texas. And then I didn't quite know what I would do after that. And eventually I found myself drawn to doing global health. And I ended up in sub-Saharan Africa in Lesotho, little tiny country completely surrounded by South Africa, basically working on the scale up of pediatric HIV care and treatment. And so that, again, was very programmatic in terms of implementation and operationalizing medical care and treatment for kids, finding kids who had HIV, testing them, treating them, and getting them onto life-saving antiretroviral medication therapy. And so I was doing that about 15 years ago in 2005. I was the second pediatrician for the country. And we essentially had 0 kids on antiretroviral therapy. So my job was to scale that up. So from now at Children's National, it was so incredible that now I find myself in another pandemic, right? Where almost everything I was doing now for the COVID epidemic, I was doing 15 years ago for HIV in sub-Saharan Africa. Yes, and so very similar in terms of the approach, in terms of messaging, of getting the community involved, of again, so almost making things up as you go along and trying to figure things out because nobody's done it before.
That's right.
So very similar in a very eerie way in terms of trying to deal with something new and then create new processes and systems in order to protect people, to protect, for me, the way I got drawn into the COVID response at Children's was through occupational health. So again, protecting our staff, our employees, and then downstream effects of protecting our patients and our families. And so, a lot of it was working with nursing, was that the nurses in this pandemic have certainly borne the brunt of it in terms of, especially in the beginning, doctors could work from home sometimes. The nurses, especially in terms of bedside, you have to go in and they were literally doing everything, for all the COVID patients because nobody else was stepping up, but nursing certainly did. And so that's how I got involved with doing the COVID response and then also obviously doing the pediatric side of the COVID response as well.
I see. So as the lead physician for the occupational health COVID-19 response, how was the experience during the design and implementation of the COVID-19 testing protocols and vaccination efforts for the employees?
Yeah, so a lot of it relied on collecting data, which is, I think, something that we did well early on in terms of building a database in order to be able to see what the patterns were in terms of transmission within the hospital, and then to be able to reassure our staff, and then to make adjustments in terms of infection control measures, in terms of testing algorithms, which symptoms we needed to look out for, and who we needed to isolate, and who we needed to quarantine, and who would likely test positive. Because as you know, there's a huge nursing shortage for one, and healthcare providers in general, especially now, that you had to balance the risk of, an employee coming to work sick with COVID versus absenteeism. Because I remember my mom, she had the little calendar up that said 3 to 11, 3 to 11, 3 to 11. And, if she had to call in sick, that was a big deal.
Yes.
And even more so now when you have, limited capacity of, people to pull from in terms of your reserves.
Mm-hmm.
So is there like a vaccine mandate at the hospital now where you are? Is everybody?
Great question.
Yeah.
Yeah, so this was something that we were probably one of the first children's hospitals to issue a vaccine mandate. And I think this was critical in terms of, it's very critical in terms of turning this around. And we issued our mandate in June.
Oh, wow.
In June, it was a totally different landscape.
Yes.
In June, in all of our hospital, we have about 8,000 employees. We had a total of 3 employee infections.
Wow.
It was at the nadir. June was definitely the nadir. And the problem is Delta came.
Yes.
And we didn't know how Delta was going to impact our numbers, but they just shot up such that we hit, basically a peak in August, early September, where we were about 30% of our peak in November and December of the prior year, when that was really where it was, hitting us hard.
Yeah.
And so by calling the mandate in June, it was important to give our staff time. People needed time to sort of get the information, the accurate information. As you know, lots of misinformation, lots of conspiracy theories that are just plain wrong. And to be able to, get used to the idea that they would need to get vaccinated, not only for their protection, but the protection of our patients who are children.
Yes.
They can't get vaccinated, less than 12.
Right.
And so to protect our patients and again, their families and eventually also the entire community. And so I think, again, having that forward thinking of doing the mandates early, giving people time to do their own research, to get the messaging right, get the right information to the right people at the right time, both physically, emotionally, and spiritually as well.
Yes.
That was really key to have. Then the mandate is we made it September 30th. So we gave people June, July, August, and September, 4 months to sort of start getting on board. And so we had a mandate. Yes, of course, we also had, they could apply for an exemption. And so, again, medical exemption and a religious exemption. But in the end, September 30th, we did not have to terminate one employee.
Wow.
Congratulations.
I see.
It was huge because, again, we know that some people just can't wrap their heads around it. And we know that they're good employees, good nurses, good doctors, good, technicians. But they have whatever their reasons are. We just mandated that they had to submit for a declination or they had to get the vaccine.
I see. You have mentioned nurses and other patients and families. How about you as a physician? How did this affect you?
Well, besides it completely changed my scope of practice. And so essentially most of my time then went to, again, doing a lot of communicating, doing a lot of town halls, doing a lot of huddles, because eventually what convinces someone to get vaccinated is not, it's that one-on-one interaction. And so, again, finding those trusted messengers, and getting the message out. And I think it also, as a practicing physician, I think the hardest thing to get used to was being in the face masks all the time and being in the pappers where you couldn't hear, you couldn't read people's lips. And it kind of changed the way you communicated with the families, where it almost put a little bit more distance. Like you don't know what they really look like. They don't know what you really look like. And I think that took a lot of getting used to. So not only could I not hear them, but they couldn't hear me. I felt like I was always yelling at them, especially when you had that papper on and the fan is going and you just can't hear anymore.
I can imagine.
That definitely changed sort of my perspective and my practice as a physician. And then I think teaching as well. So this is, I think, an unintended consequence as well, is that over the winter then for kids, we didn't have a large volume of patients in the wintertime. Right now, we're seeing our winter season come in August and September, which is very bizarre. But in terms of both nurses and doctors, then the trainees, they didn't get experience of seeing asthma, bronchiolitis, croup. And so a lot of our interns, they then became second years and they're supervising interns and they hadn't even seen it yet.
Right.
And so there was this definite change in training in terms of having to go virtual and sort of the downsides of that, of not being able to really be physically hands-on. So as a clinician educator, I definitely saw a change in that. And Manny, I know you're a professor
Yes.
as well. That whole change to go virtual
it was huge.
It took a lot of.
It was huge.
It took a lot of work.
Yes. Dr. Ferrer, you are a faculty mentor, right, for the Children's National Residence. Now, has the number of residents specializing in infectious disease and immunology been affected by the COVID pandemic as far as the numbers?
I don't think we know that yet. I think we're still in the middle of it, and we'll see those that effect in a couple of years or so in terms of people I think will become more interested in it. In terms of, this is something that, again, not only is an opportunity for you as a clinician, but certainly in the FDA, in the CDC, in terms of other opportunities for growth for a resident and other ways, non-traditional trajectories that this pandemic has sort of opened up. As you see the importance of the CDC, right? In terms of making guidelines and all the data that has to be reviewed in order to make these decisions that have huge implications. And then policy as well. You see where, again, President Biden makes his mandate, and that, can change the course of the entire country, right? And so where you see that sort of impact.
Right.
That's true.
So, although the weekly pediatric admissions reached a peak during the first week of September and has since declined in most states, along with adult COVID-19 admissions, there's a lot of states, including Michigan, Oklahoma, Utah, Delaware, and Vermont, wherein pediatric admission rates have increased in the last 2 weeks, according to the CDC. We know that more of the older Americans are vaccinated in contrast to the younger population. With the relaxation of social distancing measures, cases increased across all groups, but more children tested positive relative to the older adults. So here in the United States, the Food and Drug Administration gave full approval of the Pfizer-BioNTech COVID-19 vaccine for children ages 16 and older, and an emergency use in children 12 to 15 years of age. While this may be a welcome piece of news for many parents, some have questions before signing up their children for a vaccine appointment. So, in your practice, how has the atmosphere been with parents or caregivers of children related to the COVID vaccine?
So, really, it's been a mixed bag. I would say, there are some who are asking us to give the vaccines to their 11-year-olds and their 10-year-olds, who it's not even approved for because they believe in the safety and efficacy of it. It will protect the child. And not only that, it will allow some return to normalcy. And so it'll protect the child, it'll protect, the family and the community. But certainly there are those who are saying, okay, well, it's okay if I get it, but I don't want my kid to get it yet because, again, the number one reason typically is they're afraid of the side effects. And then number two, they don't think it's been proven in terms of the amount of time that has been spent with the development of the vaccine.
I see.
And so number one, the data that has gone to the FDA and the CDC to approve it for emergency use in 12 to 15, that clearly shows the benefit of it, the effectiveness of it, and the safety of it. in terms of looking at the number of side effects. Usually what people are most concerned about and what's sort of really hit the news is this myocarditis.
Yes.
Or basically these kids that are getting inflammation of their heart or the lining of the heart a couple of days after they get the vaccine. And again, they've reviewed all of that data. That's the one nice thing about, the United States is we have a very robust vaccine adverse events system for reporting. So you can look at, million data from millions of people. And essentially what they found that it's a very rare side effect. And not only that, typically kids recover from it. They may be in the hospital for a couple of days, but they don't have ongoing issues with their heart or anything like that, that it's something that happens and then it's done. And I think one of the other aspects to think about is if they didn't get the vaccine, then they would have an even worse time if they actually got COVID in terms of the effects on their heart.
I see.
And the effects on of potentially having those complications if they got COVID. Mm-hmm. So certainly better if you're weighing your risks and benefits to get the vaccine. And again, very rare in terms of the possibility of getting it, and the benefits clearly outweigh the risks.
I see. So if a child had a COVID-19, should they still get the vaccine?
Yes. And so the CDC has weighed in on this, that COVID-19, getting the acute infection may give you some natural immunity, which we think may protect you from getting reinfected for maybe 90 days, but we don't know how long that will last.
I see.
If you get the vaccine, that gives you, again, another layer of protection in terms of not suffering from severe disease or from death. And so they still recommend that even though you've had COVID, even though you may have measurable antibody titers, that you should still get the vaccine because it just offers that extra layer of protection, that the benefit still outweighs any risk from the vaccine. And really, it's the mRNA vaccines. I know your other guest last week had talked about it, that it is a brilliant technology and has been in development for decades. Yes. Mm-hmm. And it just so happened, in terms of the steps to getting to this vaccine, that we were able to get it to basically bail us out of this pandemic. That somebody basically put all the steps in place so that we could benefit from all of the technology that's accumulated over the past several decades so that we can have this vaccine at this point in time. And the other thing I wanted to point out is that, again, many people say, oh, but it happened too fast. So number one, it's been in development for decades. And number two, the FDA and the CDC did not skip any steps at all for the approval of any of the vaccines. Mm-hmm. And so what they did was they did things faster in terms of they did steps in parallel as opposed to in sequence. And that's how they were able to shorten that time frame to, instead of 10 years to 1.5 years. They basically took out all the bureaucracy and they made people work, more people work on it since it was a pandemic, and essentially focused all the energy and all the capacity and all the infrastructure into getting these vaccines tested, reviewed. And again, because it was a pandemic, we had more people to test it on than ever before. So they had all the numbers. And that's actually why it's taking so long to review, because they have a ton of data. And so they can review all that and know, again, that with a lot of volume in terms of the cases to look at, then we can be assured that they are safe.
Right. Dr. Ferrer, you talked about risks and benefit. Now, can we explain to our listeners, if a child gets a COVID infection, how does it affect them? And what are the possible worst outcomes from a COVID infection in children that you have seen or know about?
That is a fantastic question. And so that has been actually one of the silver linings to this pandemic, in that kids have not been as severely affected as adults. Thankfully, again, they have been able to have less morbidity and mortality compared to our older adults and our seniors. And so about probably 2% of kids who are infected end up being hospitalized. So much lower than, for example, people my parents' age, where that number is close to almost 35%. And so, again, 2% of kids who are infected will end up hospitalized. About 5 million kids thus far have been infected with COVID. And of those 5 million, in terms of death, it's less than 0.03%. So again, good numbers for kids, but it's still possible for I think there were approximately 500 or 600 deaths of kids under 18. And so one death to me is way too much for something
That's
that we
right.
don't have
That's
a
right.
vaccine
That's
for.
right. So, so go ahead, doctor.
No, I was just going to say, so it's sort of what I worried more about in terms of for my nephews in particular is that not necessarily the acute COVID illness, but the possibility of Miss C. So Miss C is something that we all had to learn about as pediatricians now. So multi-system inflammatory syndrome in children. And so this is something completely new, similar to Kawasaki disease, which we knew existed, but now occurring sort of in an older age group. And this is where you have multi-system involvement. Typically occurs 2 to 6 weeks after a COVID infection, although in kids, they may have had an asymptomatic COVID infection, and then you get this inflammatory reaction, basically a dysregulation of your immune system. And these kids are sick, and they end up in the hospital, and for potentially a prolonged amount of time, sometimes 3 weeks, sometimes a month or so. And so we don't know which kids that's going to affect and which it's not. Again, a relatively rare event, but still a possibility. And hence, that's one of the reasons why, better not to get it and not play with it than even risk that potential. And then the other one is, for adults, the scary part is long haul COVID, right? Where a majority of adults who are potentially infected have symptoms for more than 2 months, or a large number do. And again, we don't know what that looks like in kids. It doesn't seem like it's as prevalent in terms of long haul, but still something that, again, if you have a vaccine, then why even take that risk?
That's right. So I'm glad to hear that the sickness or severity of illness for children with regards to this disease is lesser than the adult. So let's say a kid gets sick. How do we allay or alleviate the parents' anxiety when their child is sick?
I think it's the usual pediatric approach in terms of reassurance and having supportive care. Usually, again, most kids do quite well with it. And almost one of the more difficult side effects is the fact that then they're not in school. They're not in school for a longer amount of time.
Yes,
and sort of the mental health impact of that has been incredibly challenging. So that's another reason to get vaccinated, because if you're vaccinated, then the likelihood of you getting quarantined is going to be less. So, for example, my nephew, he's gotten quarantined basically twice in a row. So he got quarantined, went back to school. Somebody at lunch was positive, got quarantined again. And so now the entire 6th grade is back on virtual learning. But if everybody was vaccinated, then you don't have to worry about that as much, because you certainly have decreased transmission once you are vaccinated.
Dr. Ferrer, one of the things that we've learned from this pandemic, this COVID pandemic, is how it has disproportionately affected the minorities. Now, I do know that a lot of the Filipino Americans and certainly the Latino families have a multi-generational household wherein they all, in one household, you may have grandpa, grandma, and the grandkids living together. So, have you encountered any of these families, the children, the parents, speaking about their concerns about this and how it has affected them?
Absolutely. And I think that's probably one of the biggest concerns for the Filipino community in terms of our multi-generational households. You know, that was certainly one of my fears, was that I would, you know, I spend a lot of time with my extended family and also with my parents who are older. And I think the worst possible thing would be I come home and I infect my parents who are, you know, more susceptible to severe disease, and then something bad happens. And so again, that definitely is one of the driving factors for the disparity in the COVID affecting Black and Brown communities much more than other communities, because of that multi-generational household. And the fact that, you know, Filipinos and a lot of our Black and Brown brothers and sisters, that they are working in essential positions. They're not in, you know, in positions necessarily where, you know, they can telework, i.e. our nurses, right? They have to take transportation to get to work. And they have to potentially be in crowded break rooms where they're exposed to others. And so certainly I think that's one of the driving factors. And, you know, it also has certainly a socioeconomic aspect to it, where, you know, we would have some of our Latino families say, you know, I can't test because if I am positive, or if my husband is positive, that means I can't work. And that's my livelihood. That's how I put food on the table. So I think that actually your other question about how it's impacted you as a doctor, that was quite disheartening, and really seeing that disparity grow and seeing it real time, front row of how disparity occurs, where the people who are getting, you know, hardest hit were again the most vulnerable, again the people who were most disadvantaged, and then seeing how then the epidemic was impacting them even more so than others who already had a leg up.
Right.
That's right. So what do you think we should do as health in to be able to get the equality with regards to health in itself, healthcare in itself?
That's a great question. I think the vaccine is one of them, right? In terms of increasing access to vaccines physically, so you're in actual places where people of color live and where there's they're disadvantaged neighborhoods, and then in terms of messaging, of getting, you know, to places and using trusted messengers so that they can hear accurate information, as opposed to relying on, you know, conspiracy theories, or relying to what they're reading on the internet potentially, or what they're hearing on, you know, sort of echo chambers within, you know, Facebook or wherever they're accessing their news. I think messaging is a big aspect of this. Again, in terms of trying to make it equitable access to information and to vaccines.
So we have one last question for you, Dr. Ferrer, before we let you go. What would be your message to parents and caregivers of children who are still hesitant in signing up for the COVID vaccine for their children?
I would say my message to parents would be that when the vaccine does become available for your kid's age group, we're anticipating that 5 to 11 will be approved by the FDA on October 26th by the FDA, and then approved by the CDC on November 3rd. So it's coming up, that when it does get approved, then get the kids vaccinated. And why? Because it provides protection for your child, but also prevents wider and continued continued spread of the virus. And lastly, it also blocks new variants from developing. Delta threw us a curveball, and we don't want another curveball, because we could get this under control if, again, people get vaccinated, you continue with your infection control measures, and really that this is, one of the ways that you protect your child, you protect your family, and you protect your community. And really, it's the best way for us to return not only to a sense of normalcy, but to give us some peace of mind so you don't have to always worry about it. That really it's that layers of protection of, sort of assessing your risk and then using the tools that you have been given: vaccine, masking, social distancing, ventilation. Again, using all of those to your advantage so that you can protect yourself, your family, and our community.
Well, we thank you very much, Dr. Ferrer. This has been a most pleasurable conversation. You gave us a lot of valuable information to our listeners and viewers. So thank you. We hope to engage you again in the future.
Absolutely. Thank you so much. I had a great time. It's always wonderful to chat with you, and I look forward to getting to talk again.
Thank you.
Thank you, Dr. Ferrer.
With us tonight on the second segment of our episode number 2 of Rise Up is Dr. Riza Muaricio, who's an advanced practice nurse in pediatric critical care medicine and assistant professor of undergraduate studies at the CISIC School of Nursing at University of Texas Health. Riza was inducted as Fellow of the American College of Critical Care Medicine in 2015. She's the chair of Quality and Safety Committee of the Society of Critical Care Medicine, a journal reviewer of the journal Pediatric Healthcare, chair of the Practice Committee and of the COVID-19 Heal Our Nurses Kabalikat program of the Philippine Nurses Association of America. Riza is also a board of trustee of the Philippine Nurses Association Metro Houston Foundation, and the PNAA representative to the Nursing Collaborative on Environment and Maternal, Child, and Women's Health, and to the Texans for Healthcare Access, and the chair of the Philippine Collaborative on Planetary Health. Riza also served as a past board of director at the American Association of Critical Care Nurses, and a past president of the AACN Houston Gulf Coast chapter and past president of PNA Metro Houston. Riza's research interests are in the quality of life of children and adolescents and was the co-primary investigator on quality of life measures of children and adolescents with progressive cancer. Riza is also the primary investigation for age-appropriate early mobility activities of critically ill children, anticoagulation strategies for critically ill children. Riza is also a speaker, a lecturer, for several educational presentations. So, Riza, good evening. How are you?
Hello. Good evening, Manny. How are you doing?
Riza, it's Mindy here.
Glad to be here with you.
Hi.
Hi, Mindy. Glad to see you and hear you again.
Yes. So now you had your undergraduate education in the Philippines, right? For your BSN?
Correct. I graduated from the University of San Carlos in Cebu City. We were actually the first batch. I'm always a trailblazer, Manny and Mindy. So whether here or I also trailblazed the advanced practice at Texas Children's Hospital in Houston. And the same thing in the Philippines when I was in college. We were the first batch at the University of San Carlos. So it was fun. It was a fun group, and it's always nice. I don't know if you guys know University of San Carlos. It's entrenched into engineering, and they have a lot of actually of top-notch engineering students graduate, especially in the College of Chemistry.
So from the Philippines, did you go directly to Texas?
No, I did not. I actually worked in the Union Carbide Philippines. So Union Carbide, there's Union Carbide. The mother organization is Union Carbide of America, right, in the United States. And they have an Asian corporation as well, so a branch of them, and we're part of that. So I started actually as an industrial nurse, and I should have been hired and in Davao City, But then I changed my mind when I was offered that job, because obviously the pay is much higher. So when you're young, you go for where the money is. And so that's what I did. And I was conflicted initially whether that was the right route for me, because, you know, you go into nursing, you thought you would serve people. But then my dad said, you know, he gave me a book. My dad is a very intelligent man. And instead of telling me to do, or, you know, what to do or not to do, he gave me a book to read. And from that book, I found out that it's really not, you know, you don't necessarily have to follow the book in your path. You can also create your path. And exactly what I did. And so even when I was an industrial nurse, I was into already taking care of advocating for the community issues. So I would go, the first time I developed a program for that organization, I developed a program for the workers. So I would go home and visit.
Wow.
Imagine that I would go home, visit house to house, and then create a preventive program. So I went into vaccination. I don't know if you remember in the Philippines that the government will have stocks of vaccine, and then it's not well established, I would say, because I cannot recall before that is part of us entering school. So that was my program to promote vaccination among families, including especially on children. And the people in the United States were impressed with that program. So that's how I started. And then later on, with how the Philippines was going, I got married. I decided to come over here thinking that I probably would give a better life for my children if they are here. And that's how it started. I came over, and after a year, I promised myself and my family that if I did not get them a visa, I would go back to the Philippines. And with the blessings from above, I was able to get a visa. So they were able to come over here, but that was a long and trying year to be waiting for your family. I had 2 kids at that time. So they finally came over and we started in New Jersey. And that's where I started. Yeah, New Jersey. That's where, in Secaucus, New Jersey. It's like an hour from New York City. And that's how I started my critical care nursing. I love critical care that I never left since then. Until now, I'm still with critical care.
I'm a critical care nurse too, as a background.
Yeah.
And what was your experience with regards to your family was in the Philippines and you as adapting to a new environment as a nurse?
It was certainly difficult because, you know, I had my 2 girls. I had 2 girls and a boy. The boy was born here. The 2 girls were 3 and 5. So those were the ages that I think, you know, not that they don't need their mommy at all when they're bigger, but even when they're young, they need their mom, right? Those are the formative years. And I'm always for psychology. That's my niche. Like, I thought I'm going to be a psychiatrist, but psychology, right? So I knew the first 6 years of life is really important to an individual, but I wasn't there for at least a year at least. So I said, that's why I said I promised myself that if I cannot be with them in the next year or so, then I have to go back to the Philippines. And I was blessed that I was able to get them a visa. At that time, there was a visa called Family Reunification. And so I got them, and then after another year or 2, we got an immigrant visa. So it wasn't like the long, arduous road that a lot of Filipino nurses have experienced. So we were away for a year. And going back to your question, Mindy, it was hard, lots of tears, probably more than a drum of tears flowing. But you have to do it. I always have a goal in mind that eventually when they come over here, you know, it's going to be better education, and always having education in mind. That was the reason why we want them to come over here. And I think with that, the girls matured very quickly because there was no mom that will be with them. I mean, my sisters were there and helped my husband take care of them, and as well as my parents, my husband's dad. But then I think it's different when there's no mom. So my best friend will always call me or tell me that the house is different when you're not there, and how it's being set up is different. But then my siblings would say, "Oh, the kids have gotten fat now." Because you're not there, because I won't allow them. I mean, when they were growing up, they're not allowed to eat chips or, those those food. They always need to eat healthy. Even when they were babies, I would mash those potatoes or what have you, vegetables. So no ramen, those kinds of things. But when I left, they eat a lot of ramen. They eat those barbecues along the street with lots of dust. So they eat those. That's why my brother said that they became healthy. Because now they're eating all the germs and their immune system is now robust because of that.
That's so fun. So,
yeah. It was
so
fun.
Riza, when you started nursing, pediatrics wasn't your specialization. So what brought you to pediatric critical care medicine?
It was critical care, but not necessarily pediatrics, because when I started in New York, New Jersey area, it was always been adult in critical care. When I came to Houston, I interviewed many institutions and only one pediatric institution, and that's Texas Children. And then I was impressed. When I reflected on it before I took the job, I said, I think this would be better for me because I really like kids. I like developmental, progression of children and how, the brain is formed, along those lines. And I said, so maybe I can do something when they are in intensive care. So that morphed into quality of life of children and family. And it's true, too, that they smell much better than the adult. No offense to adult people, but they smell much better and they weigh lesser than the adult people. Because I would recall when I was in New Jersey, for instance, in one of the critical care unit that I was in. I mean, when you do pediatric when you do dialysis with a 200, 300 pounder, oh my God, it's a lot of load on you. Physically, mentally, emotionally, everything, And I think, I was convinced then that it would be easier physically for me taking care of them, not knowing, though, that I was immersed in a very emotionally laden environment. Not that you don't think much when you're taking care of adult in an ICU, but I think for children, because you still think of their future. And what future they will have if they are, chronically ill or maybe even in the intensive care and then eventually will have a chronic condition, much less having a life-threatening illness that they come to you all the time that would just affect the progression of their growth.
Oh, well, you've been an APN, Advanced Practice RN in a critical care unit. So how did the pandemic affect you?
So it's not particular specific on being a critical care. And I think it's the same as what everybody was feeling when it started, that it is difficult to be in an environment where there were a lot of uncertainties. I mean, at the beginning, when the pandemic started, no one knows what to do, including PPE. Should you mask? Should you have an N95? And the PPE was also in short supply. So that was more of the difficulty to me, not very much about critical care. And at that time, too, there were not a lot of kids sick with COVID, right? It was mostly the adult. So this increase in the incidence of COVID admissions happened when the Delta variant came in. And because a lot of the adults, especially those that are 65 and older, have been vaccinated, and this age group that I'm taking care of are not. Until finally, there was a vaccine for the adolescents and young adults. That's the 12 now to 18. And so at the beginning it wasn't. So basically it was the same as everybody, fear of anything, fear of the unknown, that I don't know what's going on. And then in the intensive care, which I think is similar to other intensive care, you're around with a slew of people and social distancing cannot happen. And there was no regulation at the beginning of how do you round with everybody in the intensive care when there's a lot of specialists that you round with them together, because there's certainly more of advantage when you round with other disciplines, not only, the ICU during rounding. So that adds more to the number of people during daily rounds. So that was it. And then us being a provider in the intensive care, we do a lot of invasive procedures, and one of those is intubation. But then quickly our leadership recalibrated and said, just have the physician to do the intubation. So there are specific group of people that can intubate. And so we are not exposed at all to it, because I was scared, intubating kids. And we know from the beginning that the transmission is through that route. So that really scared me a lot. I was getting paranoid and many more. And you just have to, again, to be, prayerful and make sure that you take care of yourself, which is actually very hard. It's easier said than done. I try to take care of my staff, but again, easier said than done. But eventually you recalibrate, thanks to God, and hone your resilient skills. So now, even though that, we're still in COVID, at least there is some little bit of comfort that I always remind myself not to be, just confident about it and nonchalant about things. But because COVID is still there no matter what. The good thing about it is because I am vaccinated, so there's a bit of confidence in taking up invasive procedures or be with other people, even though, when you're around or when you're in intensive care, there's many of you and social distancing is not happening. Let's just be honest about that. But we are masking and we are vaccinated. So that's better.
Riza, here in the U.S., the FDA, the Food and Drug Administration, already gave full approval for the Pfizer-BioNTech COVID-19 vaccine for children aged 16 and older, and an emergency use in the children 12 to 15 years of age. In your encounter with families with their children, what is the atmosphere there? Do you get a lot of questions related to it?
A lot
To
you mean
the
related to
vaccine
COVID?
and to the COVID, yeah, specifically for the pediatric population.
Yeah, they do have, the question is really about the safety.
Okay.
And so what we do with children alone, I mean, we talk to parents and families a lot, right? And whether it's about the COVID condition or the COVID disease alone, even though their children are not admitted because of COVID, there are parents. Not all of them are in the intensive care because of COVID, right? Even though that their children are admitted not because of COVID, you still get question of the COVID disease and the COVID vaccine. And so the atmosphere in the intensive care is the same thing as when in any critical care environment. There's not much change except when they know that a neighboring, patient has COVID. They would try to, retract from that area, which is good. They don't need to be there. There are also families that are recalcitrant in trying to think of, the vaccination because they think that no amount of vaccine can prevent them. And that's usually the challenge. However, I think when families ask me those, you always want to ask about their story, much as you would offer their story as well. So when they ask me about question of COVID disease, I would give examples of kids that are admitted because of COVID. And in the critical care environment, I would tell them, while there's a lot of kids that when they get admitted to the critical care, they go home just fine, and some of them with oxygen. However, there's percentage of those kids that are in extracorporeal membrane oxygenation or ECMO. So requiring, in other words, I don't use the word ECMO to the family. I just said requiring more technology on that more than anyone else, and are in the ICU longer than anybody else. And there's a lot of reason for that. So I gave them who are those kids that are staying longer in the intensive care because of COVID, right? And those are people with comorbidities, certainly. So one, I'll tell them a story about that, how this family is agonizing about, how their child has COVID and this mom has to take care of other children. And in addition to that, she herself, for instance, I gave this mom a story about another mom who has other children to take care of. And she's a single mom. And so that and coming to the intensive care and taking care of other kids, she doesn't have, an army of support to handle all of those, in addition to a single mom, a single breadwinner. And so if she is divided between children in the ICU and children at home, who's going to take care of their food? Who's going to, where would they get money to buy food on the table? And so I said to that family that there's definitely a lot of burden when you have that kind of disease. So that's why it's very important that their children need to be vaccinated if the vaccine is available, because there are still ages that doesn't have availability of vaccine, right? The younger than 12 years of age. And so that is still not available. And I said, plus the fact too that the science of COVID is still new and we don't know what's going to happen to our kids that will have COVID. Yes, they are going home. Some of them are just on oxygen. So, better than children that died, definitely. But then again, you don't know what's going to happen to them in the long run, because we know that in the adult science, when this happened last year, a lot of the adults got sick. And the science that's available for those adults that went home, there's a lot of complications, what they call the neurobrain, that they get foggy. And so think about a child that still has a developing brain, and then eventually, because they're sick with COVID, that complication happens to them. So what's going to happen to their brain development or their development in itself? So I give them examples of what's potentially going to happen so that they can mull and think about it, especially those that are hesitant and recalcitrant to vaccines. And, I respect, especially those that have negative opinions of vaccine. I respect their opinion because, diverse people have diverse ideas, but then also having them realize what's going to happen if they don't have, because there's solid research now that has shown that if children are exposed to unvaccinated group of people, whether it's adult or other children, hence those that are going back to school, and they are with friends or classmates that are unvaccinated, they get it as well. And what if they get it and they are those small percentage of kids that become very, very sick and would be on, cardiopulmonary support, right? And what's going to happen to them in the future. And so telling them a story, definitely to have that understanding. And I also, when you dig deeper into family's life, you would also realize that actually the reason why they don't want the vaccine is not because, or they didn't get the vaccine themselves as an adult, it's not because they don't want the vaccine, because they don't have a transportation to go to the vaccine hub, or they cannot afford to be off work because, if they're off work, then they're not paid, right? Because there are places, there are employers that if you don't work, you don't have a pay. So if you're the only breadwinner in the family and you're not paid even for a day or two, because, some gets a vaccine for that day, the following day they're still off because of whatever side effect. I think especially me that got the vaccine, I have to sleep the whole day. So that would require 2 days already. And some people cannot afford to have that. And so I think those are the things that we need to consider when talking about people. Certainly, what is important, I think, for me, talking about COVID, this disease, and the vaccine, it's important to have that understanding and communication, because that's the only way I think we can help one another. Because if you don't have that dialogue, then, and you just pretend that, someone is foolish or someone is, acting not right and labeling each other, the more we would be at war with each other instead of helping one another. And I think that's just my principle of taking care of people.
And other than the disease processes that you have mentioned and treatment, what other things that you have learned from this pandemic?
Many things. To begin with, if you talk about communicable, like just community nursing or community health, we were not ready with this pandemic, right? And I think we all know that. Not only we in the United States, but the whole world. But come to think about it, I always rely on science and always relying on the United States being the grand, nation that can support R&D, the research and development, or always ahead, especially in terms of technology. But then we were not ready with the pandemic because we don't even have that group of people that were tasked to do, emergent or emerging diseases, communicable diseases. That was, I think, abolished by the previous administration. So not going into politics, but just the reality. And in fact, there was a congress or a conference of experts in infectious disease and virology the year prior to, I would say, when COVID hit. And we all know, the world know that we were not ready because there were a lot of action plans that needed to happen. That did not happen. And then this COVID hit. For instance, as nurses, we know this. There were no PPEs to begin with. So we were all scared. Like, how can you take care of, an infected person? That transmissibility of the disease is so high, especially with this Delta variant. But then at the beginning, you also know that the transmission is very high, but you don't have the proper PPE to take care of them. Imagine I wore an N95 that was worn by another person the previous day. Come to think of that, that has never happened in my life, in my 30-some years in the United States, but it did happen. And for United States to be doing that, right? We're supposed to be the standard of care. And I know they said research has shown that it's okay. In a way, it's disinfected or sterilized or what have you. But still, that's in your mind that this was worn by another person. And some of them even have like the makeup marks. But you have to use it because there's nothing else that you can use. And you have to wear an N95 because you're taking care of patients. And, just things like that. And you have to have a goggles as well to be going around. So you go around with a foggy goggle. And it was really a truly amazing adjustment. So that's one in terms of what have I learned. The other thing I have learned also that none of us have been to any pandemic, right? I should say none. I think there was an over 100-year-old lady that was in the flu pandemic in the 1918. But anyway, most of us never been to a pandemic. And I think what I've learned from this pandemic that hopefully there's none in the future, but it if ever there is one, there should be a united front, same communication and consistent communication for everybody. Because I think what's happening to us is there's a lot of noises. And when I say noise, that's the misinformation. And we are not focused on something that all of us should follow. And because of that, anyone can just do whatever they want to do. Compared to other countries when their leadership, government leader says, we need to do this, we need to do that, and they all followed, their numbers are lower than what we have. And to know that United States is the number one in terms of incidence and death in the whole world, I think that's a very disappointing thing. Because, we as a country, we have the money, we have all the technology, but a lot of people are dying. And it's certainly very disheartening to me, not only because I'm a pediatric nurse, but also to have 4 kids to die and the disease is preventable. It's really disheartening. It's so sad. Children are not supposed to die this early, right?
Yeah.
They're still so young. They have a lot of future ahead of them, but a lot of their lives are cut short because of COVID and because of something that could have been prevented.
So, Riza, what would then be your message to parents and caregivers of children who are eligible for the vaccine, but whose parents or caregivers are hesitant in signing up for the COVID vaccine for their children? What would you tell them?
It's very simple. They need their children to be vaccinated, and they should be the role model of their children. Because once mom and dad are vaccinated, or aunts and uncles are vaccinated, the children would say too, "Why can I not have that? If you think that that's also good for you, that also will be good for me, right?" So they need their children vaccinated. And if they don't want to be vaccinated, my plea to them is have your children vaccinated, because you don't want their lives to be cut short because of a preventable disease. I mean, when you become a mom and a dad, you have plans and dreams for your children, right? And all of us have dreams for our kids to be doing well, to be dancing well, to be singing, whatever, and to have a happy life. And then for that to be cut short because of a preventable disease, I don't think that if I'm a mom, I would forgive myself. And I would say the same thing to a mom. And I have said that. And I've said that. And I said, if I have little children now, and even though the vaccine, is still new, because that's always the reason why they don't want their children vaccinated, right? Because they're afraid of the side effect. And it is understandable, because in any change, there's always going to be an early adopters and the late adopters. But you would just wish that those late adopters will have that decision before something happened to their children. And I said that to several of the moms that I've talked to, and that would ask me that I don't want my children's life to be cut short because of a preventable disease. Because you, as a mom or as a dad, you would try your best to do anything and everything for your children. And I think that's just, a fact for any kind of mom or dad.
Should a child that had COVID still get the vaccine?
Yeah. I mean, anyone, whether child or adult, they should still get a vaccine. And there's a stipulation in terms of the period. It's 90 days after they were diagnosed with COVID. They still need to get the vaccine because we don't know. As I said, the science on COVID is still new. So we don't know on how natural immunity or from the COVID disease, the acquired immunity from having COVID would last. We don't know that. I think the science that has come out derived from adults that had COVID, the antibodies would wane.
I see.
So that's why they still need to get the vaccine.
So, Riza, now children also have routine vaccines that they have to get, in addition to the COVID vaccine. So how does the COVID vaccine affect the schedule of the other routine vaccines for children?
I would say it depends on what age group these children were talking about. Well, for number one, they can actually get other vaccines in addition to COVID, but that certainly creates an angst among parents, right? Because, you're giving me gazillion, but come to think about it, in scheduled vaccines, there are vaccines that are given, like MMR, DTaP are given together, right? So that's also is a lot. And certainly if you still add COVID and flu, and that's more. But only that portion of the age group will they still are having frequent vaccination. So the older they are, the lesser vaccines they are getting. And so that should not be a problem. The only thing that we need to think of is giving flu vaccines, which is now to children, and in addition to also giving COVID vaccine because, the 12 and above are able to get vaccine now. And what if the 5 to 11 will also be approved, and that discussion with FDA and, CDC and what have you will going to happen, I think, 2 weeks from now, October 26th. And so that's coming up in November. So I'm sure the parents will have that anxiety of what to do, having to give flu and COVID together. So my advice right now to parents that, are listening or would be listening to this podcast is get the flu vaccine now, such that when that vaccine becomes available to your child in that age group lesser than 12 years of age, then only one vaccine can be given. So that angst of giving many vaccine, will be prevented because you are planning it. And that's what I told the parents, plan ahead of time. Not all of your kids are scheduled to have vaccine now. So planning will definitely help them in terms of anxiety and also in taking care of them because you don't know the reaction of children to the COVID vaccine. I mean, even us adults has reaction to it and even a reaction to flu vaccine as well. So if you put that all together, that's probably where the anxiety is coming from. But if you plan it ahead of time, so it would be much better for parents to handle, I would say.
Have you seen worst outcomes from this disease?
Absolutely. That's why they're in intensive care because I've seen worse outcomes. So those are rare though, but of course the rarest of all the outcomes will come to us. And in those are the kids that are diagnosed with what they call the MIS-C, the multi-inflammatory response syndrome. And because many of them, some MIS-Cs are not in the ICU, but there are a group of children that are in the intensive care, and they will be having a lot of supportive device, cardiorespiratory support device, including, ECMO. And, I'm also happy to say that amongst the children that are requiring a lot of support, they have gotten out of the ICU, except again, those that have a lot of comorbidities with chronic conditions.
It's been a pleasure, Riza, speaking with you and a wealth of knowledge you've shared with us and a lot of interesting stories. We thank you. And this is all that we have for this episode. I want to thank our guests, Dr. Riza Muaricio and Dr. Kathleen Ferrer, and of course, my co-host, Mindy Ofiana, our director and producer, Rodney Cajudo, our executive producers, PNAA President, Dr. Mary Joy Garcia-Dia, and PNAA Executive Director, Carmina Bautista, and our advisor, Nancy Hoff. And we will see you again next time here on Rise Up. Until then, keep on rising. See you next week. Thank you. Bye.
Goodbye.
Bye-bye.
Bye.
Thank you. Bye.
Thank you too.